Welcome back to the deep dive. We are doing something a little different today. Usually we take a topic and drill down into the microscopic details. We're looking at the pixels. But today we are going the other way. We are zooming out way, way out.
We are trading the microscope for the telescope today.
That is the perfect way to put it. And we are speaking specifically to the nursing students in the audience today. We know exactly where your heads are at right now.
Oh, yeah.
You are likely knee-deep in pharmacology flashcards. You are memorizing the Krebs cycle until your eyes cross. And you are trying to remember the normal range for potassium to the decimal point. It is all very focused on the individual body in the bed.
Which is critical, obviously. I mean, you absolutely need those skills to keep people alive.
Of course.
But the sources we are covering today, and we have a massive stack of material here on global health, disaster management, and the epidemiology of violence, they argue that if you stop at the bedside, you are actually missing half the picture.
We are unpacking the concept of the world as client. And I will be honest with you, when I first saw that phrase in the reading list, it sounded a bit fluffy.
Little bit, yeah.
It sounded like a slogan on a poster in a guidance counselor's office. The world is your client.
It does sound a bit abstract. But then you start reading the data, and you realize this isn't abstract at all. It is terrifyingly concrete. The core theme here is that global is local. And that is not just a catchy phrase for a bumper sticker.
No, it is a logistical reality. In nursing, there is often this mental divide. We have all done it. There is us here in the developed world and them over there in developing nations. We think of global health as something that happens to other people in other places. But the sources make it crystal clear. There is no them. There is only us.
Think about the interconnectedness of our systems. I mean, a virus doesn't check a passport. A natural disaster doesn't stop at a state line.
The statistic that really hammered this home for me was about viral transmission and air travel.
The 36-hour rule.
Right. A pathogen can travel from a remote village on one continent to a major metropolitan hub on another in less than 36 hours via commercial air travel.
That is barely a day and a half.
A day and a half.
And think about the biology of that. Think about the incubation period of most viruses. You could be infected, board a plane, land, go to a business meeting, go to a concert, and kiss your kids goodnight before you even run a fever.
You're a vector before you even know you're sick.
Exactly. By the time the first symptom shows up, the biological event is already global.
So the community or public health nurse, the CPHN, isn't just checking immunization records in a dusty basement somewhere. They are essentially the first line of defense in a global biological context.
Absolutely. And it is not just pandemics. It is natural disasters spreading across regions. It is violence rippling through a community like a contagion.
Okay, so that's the mission for today's deep dive. We want to equip you, the nursing student, with the high-level frameworks to handle this. We are not just memorizing definitions for the NCLEX here, although, let's be honest, this will help you pass.
It will definitely help. But we are trying to figure out how to assess the world as a patient.
We have a roadmap for this. We're going to start with global health and the burden of disease.
Right.
Then we are going to look at what happens when the systems crash. That's disaster management.
Yeah, when everything goes wrong.
And finally, we are going to tackle a topic that I think is going to surprise a lot of people. Violence as a public health epidemic.
It is a heavy stack, but it is all connected. You'll see.
Let's jump into part one, global health. And I want to go back to that us versus them mentality. The Global Health Council has some pretty strong words about this in the source material.
They do. They explicitly state that nurses need to abandon the idea that global health is solely about international aid work. You don't have to join Doctors Without Borders or fly to a different continent to practice global health nursing.
Because the world has come to you.
The world has absolutely come to you.
The sources use the Los Angeles Unified School District as the prime example here. Now, obviously, LA is a massive melting pot.
It is the second largest school district in the nation, and the data shows that the students there speak 92 different languages at home.
92 languages.
92.
That is basically the United Nations in a single school district. So if you are a school nurse there, you are not just dealing with American health standards.
Not at all. You are dealing with cultural beliefs regarding health, illness, and treatment from 92 different backgrounds.
But here is the kicker, and this is where the global is local concept really lands. It is not just the big cities. The source material highlights rural Montana.
Right.
Now, when you think of Montana, you think of wide open spaces, maybe a more homogeneous population.
You don't typically think global crossroads.
You know.
But even there, Families speak 22 different world languages in their homes. So if you are a nurse in rural Montana or LA or anywhere in between, your local patient population is a global population.
This means cultural competence isn't just an HR requirement or a nice-to-have soft skill. It is a core clinical competency.
Oh, absolutely. If you don't understand the cultural context, you might miss the diagnosis completely.
Or the treatment plan will fail because it doesn't align with the family's belief system.
Exactly. If you prescribe a regimen that violates a patient's cultural or religious dietary restrictions, they aren't going to follow it. That's a clinical failure, not a patient compliance failure.
To understand where these populations are coming from, the sources break history down into three eras of health. They call them epidemiologic transitions. And reading through this, it feels like we are currently living in a weird, messy overlap of all three.
We absolutely are. But historically, they tend to move in a sequence. Let's walk through them because they explain the why behind the patients you see. The first is the era of infectious diseases.
This is the default setting for most of human history, right?
Correct. High birth rates, but also very high death rates. Life expectancy was low, often in the 30s or 40s.
Wow.
Families had many children, 6, 7, 8 kids, not just for labor, but because, tragically, they knew a significant percentage wouldn't survive to adulthood.
This is the era of the plague, tuberculosis, measles, cholera, things that just wiped people out before they could get old.
The primary threat to health was a bug, a pathogen.
Then something changes the game. We transition to the era of chronic, long-term health conditions. What is the driver here?
Well, there are a few things, but the big one is antibiotics.
Antibiotics, and I assume sanitation, clean water.
Exactly. Antibiotics, vaccines, and clean water. Suddenly, children aren't dying from simple infections at age 5. They are surviving. And because they are surviving, they are aging.
And because they are aging, they have time to develop the wear and tear diseases.
Precisely. You live long enough to get heart disease. You live long enough to get cancer, arthritis, diabetes. In this era, the birth rates start to drop.
Why is that?
Because parents realize their children are going to survive, so they don't feel the need to have as many. The population stabilizes, but the medical focus shifts from curing the plague to managing the condition.
And that leads us to where we are now, or at least where the developed world is heading, the era of social health conditions.
This is the new frontier, and it is the most complex one. The source material uses a very specific slogan here that I think every nursing student needs to internalize.
What's that?
Where you live determines your health.
That is a heavy statement. It implies that your address is a medical vital sign.
It is supported by the data. This era is defined by issues like addiction, obesity, gang violence, human trafficking, and mental health crises.
These aren't caused by a bacteria or a virus in the traditional sense.
No. You can't vaccinate against a zip code that has no grocery stores and high crime rates.
This connects to the zip code effect. I've read that in some cities, a difference of 5 miles in where you live can mean a 10-year difference in life expectancy.
That is the reality of the social health era. These conditions are rooted in social behaviors and environmental conditions. If you are a nurse today, you are treating the downstream effects of these upstream social problems.
So we have these three eras, but the problem is different parts of the world and even different parts of the same city are in different eras simultaneously.
That is the challenge. You might have a patient who recently immigrated from a nation where infectious disease is still the primary killer, so they are coming from era 1.
Okay.
They move to a neighborhood in the U.S. that is struggling with gang violence and addiction era 3, and meanwhile, they're trying to manage their grandmother's diabetes era 2.
It is a collision of eras.
Total collision. And alongside this, we have the demographic transitions. You have the long life, small family model seen in wealthy nations. This change happened slowly over centuries for places like Europe and North America.
It was gradual.
Very gradual.
Yeah.
But in low-income nations, you have the short life, large family model transitioning very rapidly.
Because we are exporting medical technology.
Exactly. We drop vaccines and antibiotics into a developing nation. Death rates plummet almost overnight.
Yeah.
But cultural norms around family size take generations to change.
So birth rates stay high while death rates drop.
Right? Resulting in a population explosion. And specifically, a youth bulge. You have these massive young populations in developing nations. That creates a unique set of healthcare challenges: education, jobs, sexual health, violence prevention.
Okay, I want to pivot to the math. I know. The nurses listening are rolling their eyes right now.
I didn't go to nursing school to do statistics.
Right. But this concept is crucial for understanding how decisions are made. The sources talk about the GBD, the global burden of disease.
If you want to understand health policy, you have to understand the GBD. The old way of thinking was just counting bodies. How many people died of malaria? How many died of cancer?
Just mortality rates.
That's right. But mortality misses the picture. If a disease doesn't kill you but leaves you bedridden, blind, or in chronic pain for 40 years, that is a huge cost to society.
Sure, the person can't work, they need care, the family loses income.
Exactly. Mortality rates don't capture that suffering. So they needed a new metric.
So they invented a new metric, the daily.
The disability-adjusted life year.
I call this the math of misery.
It is a bleak but necessary calculation. The formula is years of life lost, YLL, plus years lived with disability, YLD.
Let's break that down. Let's make it concrete. The source uses the measles vaccine as an example.
Okay, so imagine a community in a developing nation. Before the vaccine, children frequently died of measles at age 5.
Okay.
If the life expectancy is, say, 65, that child lost 60 years of life. That is a huge years of life lost number.
You're huge YLL.
Got it. Now, there are other kids who survive the measles, but they end up blind or with brain damage due to encephalitis, a common complication. They live to 65, but they live 60 years with a significant disability. That drives up the years lived with disability.
The YLD.
So the total daily score for that community is through the roof. It represents all that lost potential, all that suffering.
Okay, so that's the problem. What's the solution?
Now, you introduce a vaccine campaign. Hopefully the deaths drop to 0, so YLL becomes 0. But you also prevent the blindness and brain damage, so YLD drops.
So when you add those together, the total burden on that community plummets.
Right. And that translates to economic growth. Healthy kids go to school. Healthy adults go to work. The daily allows governments and organizations like the WHO to compare apples to oranges.
How does the burden of depression compare to the burden of tuberculosis?
Exactly. The daily gives you a common currency to measure the impact. It helps you decide where to spend the money. It is analyzing health as an investment.
Speaking of investments, let's talk about success stories. We often hear about how broken healthcare systems are, but the sources highlight the Alma Ata Declaration of 1978. This was a turning point.
It was the moment the world realized that hospitals do not equal health. Before 1978, the focus was on the ivory tower model. Build big, expensive, shiny hospitals in the capital city.
Which is great if you live in the capital city, not so great if you are a farmer 3 days away by bus.
Exactly. The Alma Ata Declaration said, no, we need health for all. It shifted the focus to primary health care, or PHC, community-based care, prevention, local clinics.
And the proof is in the pudding. The Portugal case study in the notes blew my mind.
It is a classic example of policy done right. In the 1970s, Portugal was struggling with health outcomes. They decided to reorganize their entire system into family health units.
What did that look like? Was it just renaming clinics?
No, it was a fundamental shift. Instead of just random doctors, they created teams. A physician, a nurse, and administrative staff were responsible for a specific local population. They knew their patients by name. They tracked them. They followed up.
And the results?
Infant mortality dropped by 50% every 8 years.
Wait, say that again? 50%?
50% every 8 years. That is exponential improvement.
That's unbelievable.
It is staggering. And life expectancy jumped 9.2 years in a single generation. Think about that. That is essentially adding a decade of life to an entire population. They didn't do it by inventing a new wonder drug. They did it by organizing care differently.
That is the power of the world as client perspective. It is systems thinking.
It is.
And we're seeing modern versions of this with telehealth. The sources mention Brazil and India specifically.
This is the Alma Ata model updated for the digital age. In Minas Gerais, Brazil, they connected over 600 municipalities. These are rural areas.
Okay.
By having specialists available via telehealth to consult with a local nurse or doctor, they prevented 81% of referrals from leaving the local community.
That is huge for a rural patient, not having to travel hours to the city just for a consultation. That saves money, it saves time, it keeps people compliant with treatment.
And in India, they are using portable EKG tablets in rural clinics. Low-cost, rugged tech. They take the EKG, it generates a PDF, and they send it to a cardiologist via Wi-Fi hotspot.
It is democratization of healthcare.
It is. It is moving the expertise to the patient.
Yeah.
Rather than moving the patient to the expertise.
So that is the world as client. We are moving from infectious to social issues. We are measuring the burden of disease and lost time, the daily, and we are seeing that community-based care works.
Correct. But
Yeah.
even the best systems have breaking points.
Which brings us to part 2, disaster management, when the system fails.
When chaos takes over.
Right. The definition of a disaster in the sources is actually quite specific. It is not just something bad happened.
No, a bad car accident is an emergency. A house fire is an emergency. A disaster is defined as an event where the destruction exceeds the community's ability to respond without outside help.
So it is a resource equation. Demand is greater than supply.
Exactly. If you can handle it with your own fire department and hospital, it is an emergency. If you need the next 3 counties and the National Guard to show up, it is a disaster.
And we categorize these by casualty numbers. A multiple casualty incident is more than 2 but less than 100 people.
Which strains the system, sure. A 50-car pileup strains a hospital.
Yeah.
But a mass casualty incident, over 100 people, that overwhelms even large cities. That is when the rules change.
And this is where it gets really interesting and, frankly, really difficult for the nursing students listening. The ethics of nursing actually flip during a disaster.
They do, and this is the hardest concept to teach because it goes against every instinct a nurse has. In a normal ER setting, the standard of care applies. If a patient comes in critical, let's say they have coded, you put all your resources into saving them. You treat the most critical patient first.
You fight for every life.
You fight for every life. But in a disaster, you shift to crisis standards of care. The goal becomes the greatest good for the greatest number.
Which means the math changes.
The math changes completely. If you have limited resources, limited doctors, limited ventilators, limited bandages, and hundreds of victims, you cannot spend an hour trying to revive one person who has a 5% chance of survival.
Because in that hour, 3 other people who had an 80% chance of survival might die because you weren't treating them.
Exactly. So that critical person, who would be your top priority on a Tuesday night in the ER, is categorized as non-salvageable or expectant in a disaster.
It is the black tag in triage.
It is emotionally devastating. You are tagging a living, breathing person, or someone who has just stopped breathing, as do not treat. You are walking past them to save someone else.
I can't even imagine. That is the moral injury that comes with disaster nursing. It forces you to make impossible choices.
It is, and that is why disaster preparedness is so psychological. You have to know the framework before you get there, or you will freeze.
Let's talk about that preparation. We have the cycle of disaster: prevention, preparedness, response, and recovery. The preparedness section had a fascinating historical nugget about the civil defense era.
Yes, the 1961 handbook. This was the height of the Cold War. The fear of nuclear attack was real.
Sure.
And the handbook explicitly acknowledged a terrifying reality. In a major catastrophe, nurses might choose their families over their duty. They might not show up to work.
And you can't blame them.
Not at all. If you don't know if your children are safe, can you effectively triage patients? The guidance, which still stands today, is that personal preparedness is professional preparedness.
You need a family plan.
You need to know where your family will meet. You need a stockpile of water and food at home.
Yeah.
You need to know your kids are safe with a neighbor or a plan.
Put your own oxygen mask on first.
Only when your personal anxiety is managed can you put on the uniform and function as a nurse in a disaster zone.
Exactly.
Now, once the disaster hits, we go through psychological phases. It is not just a flat line of misery. It is a roller coaster.
It is. First, you have the heroic phase. The event just happened. Adrenaline is pumping. People are running into burning buildings. Nurses are working 24 hours straight.
Everyone is fueled by cortisol and the need to save lives.
Right. Then comes the honeymoon phase. This is usually a few days to a few weeks in. The media trucks arrive. The GoFundMe pages start. The community comes together. We are Boston strong. We are Vegas strong.
There is a sense of cohesion and shared purpose. Everyone is hugging.
Right. But that doesn't last. Gravity kicks in, then comes the crash, the disillusionment phase.
That sounds ominous.
It is. The adrenaline wears off, the media leaves, the insurance checks are delayed, the bureaucracy kicks in, people are living in trailers, they are exhausted, they are hungry, and they are angry.
This seems like the danger zone for mental health. It is. This is where suicides spike. This is where domestic violence spikes. This is where substance abuse starts. For a public health nurse, the disillusionment phase is where the real work awfully begins.
You are not bandaging wounds anymore. You are trying to hold a community psyche together.
That's it, exactly. And finally, you get to reconstruction, the new normal, which can take years. Just look at New Orleans post-Katrina. Reconstruction is a generational project.
We have to talk about the California gas leak example from the sources. We often think of disasters as explosions or hurricanes, loud, fast events. But this was a hidden disaster.
Aliso Canyon, 2015. It wasn't a bang, it was a hiss. A natural gas storage, well ruptured underground. It released 30,000 kilograms of methane into the air every hour.
Every hour. And nobody knew at first?
Not immediately. Residents just started getting nosebleeds, headaches, respiratory issues. Pets started getting sick.
This is a perfect example of why nurses need to look for patterns.
Exactly. If one patient comes to the clinic with a nosebleed, it is a nosebleed. If 10 patients from the same street come in with nosebleeds on the same day, that is a public health signal. The nurse is often the sensor that detects the disaster before the official alarm goes off.
And speaking of response infrastructure, the sources mention California's mobile field hospitals.
These are incredibly impressive. They are modeled after the Navy and Air Force deployable units. We are talking about 200-bed 10 hospitals that can be deployed and operational within 72 hours.
That is not just a first aid tent.
No. They have surgical suites, ICUs, X-ray machines, pharmacies. They bring their own power, their own water. It shows that preparedness requires hard infrastructure, not just good intentions. You need the gear.
So we have covered the world, and we have covered when the world falls apart. Now we need to talk about something that is often treated as a crime, but the sources argue is actually a public health epidemic: violence.
This is a major paradigm shift. For a long time, violence was the domain of the police and the courts. You arrest the bad guy, you put him in jail. Done.
But in 1985, Surgeon General C. Everett Koop challenged that.
He did. He stood up and said violence is a public health issue.
Why? What does that change?
It changes how you treat it. If it is a crime, you act after the fact. You punish. If it is a public health issue, you treat it like a disease. You look for the root cause. You look for transmission. And most importantly, you look for prevention.
And the sources get into the neurobiology of trauma. This is not just bad behavior or poor choices.
No, trauma physically changes the brain structure. We know this now. Severe or repeated trauma affects the amygdala, the threat detection center, and the prefrontal cortex, the decision-making center.
So the alarm system is stuck in the on position and the brakes are cut.
Precisely. A victim of violence might not behave rationally in a medical setting. They might be aggressive or withdrawn, or their story might not make sense. They are in a state of neurobiological dysregulation.
So a nurse practicing trauma-informed care isn't judging that behavior.
Right. They aren't thinking this patient is being difficult. They are thinking this patient is reacting to trauma. It changes your entire approach. You ask permission before touching. You explain every step. You empower them. You avoid re-traumatizing them.
Let's break down the types of violence mentioned. Intimate partner violence, or IPV. The sources mention a very specific high-risk time for women.
Pregnancy. It is a massive risk factor for the escalation of abuse.
Which is horrifying to think about. You would hope pregnancy would be a protective time.
Sadly, the data shows the opposite. The stress, the change in focus, the loss of control for the abuser, it often triggers violence. That is why assessment for danger and lethality is mandatory during prenatal visits.
But here is the key for students. Protocol matters. The words you use matter. You do not walk in and ask, are you being raped? Or is there violence at home?
No. Those words, rape, abuse, violence, they are loaded. They are stigmatizing. A victim might not identify with those terms yet. They might think, well, he doesn't hit me, he just pushes me. So if you ask, is there violence? They say no.
So how do you ask?
You focus on safety and behavior. Do you feel safe at home? Does your partner prevent you from sleeping? Has anyone hit, kicked, or hurt you?
You describe the actions, not the category.
Exactly. It opens the door without forcing the label.
And then there is child abuse. There was a specific condition mentioned that is rare but fascinating and tragic. Munchausen syndrome by proxy.
This is a complex mental illness where a caregiver, usually a parent, induces illness or fabricates symptoms in a child to get attention for themselves.
They poison the child or tamper with lab samples.
It is incredibly dangerous. And the stat on the perpetrators is something every nurse needs to hear.
What is it?
85% to 98% are the biological mother.
Wow. That's a hard pill to swallow.
It creates a cognitive dissonance. We are trained to trust the mother, to view the mother as the protector.
Right. In pediatrics, the rule is usually listen to the mom. She knows the child best. But in these rare cases, the mother is the danger. It requires a very high level of suspicion and objective assessment. You have to be willing to question your own bias about what a good mother looks like. Then we have elder abuse. The sources call them the invisible victims.
And they really are. 1 in 10 older adults experience abuse, but they rarely report it.
Why?
Fear. And it is a specific kind of fear. If you are 85, frail, maybe have early dementia, and your abuser is also your caregiver, maybe your son or daughter, you are in a bind.
You need them to survive.
Exactly. They are terrified that if they report the abuse, the caregiver will be removed and they will end up alone in a state-run nursing home. They often fear abandonment and institutionalization more than they fear the abuse.
That is heartbreaking.
It is. The highest risk group is women over 85. They are the most vulnerable.
And finally, human trafficking. The sources say nurses are often the only professionals these victims interact with.
Think about it. A victim isn't going to school. They aren't going to the bank. But they get sick. They get injured. They get pregnant. They might end up in an ER or a clinic.
That moment is a tiny window of opportunity.
It might be the only window, so you have to know the red flags.
So what are the red flags?
It is subtle. Inconsistent stories. Not knowing their own address or where they are. And mostly the behavior of the person with them. Is there a boyfriend or uncle who refuses to leave the room? Does he answer all the questions for her?
Does he hold her ID?
Right. If you see a patient who isn't allowed to speak for themselves, who seems fearful of the person they're with, your radar needs to go way, way up.
Now, violence prevention isn't just about stopping the bad. The sources talk about sources of strength for suicide prevention. I really like this approach.
It is a great program because it flips the script. Traditional suicide prevention often focuses on the risk factors. Depression, anxiety, isolation. It focuses on the whole.
Sources of strength focuses on the latter out of the whole.
Exactly. It identifies 8 strengths or protective factors. Mentors, positive friends, family support, mental health access, medical access, spirituality, generosity, and healthy activities.
It is proactive. It is building a shield before the arrow hits.
And it uses peer leaders. It is not just adults lecturing kids. It is kids influencing kids to seek help and build these strengths. It changes the culture of the school.
Okay, we have covered a massive amount of ground. Global health, areas of disease, disaster triage, hidden gas leaks, the neurobiology of violence. It feels like a lot of different moving parts. But part 4 is about synthesis. How do we bring this all together into one toolkit?
We use the universal framework of prevention. This is the bread and butter of public health nursing. It organizes everything we just talked about into 3 buckets: primary, secondary, and tertiary prevention.
This is going to be on the test, folks, but more importantly, it is how you organize your brain. Let's apply this framework to the 3 topics we just discussed. Let's start with primary prevention, stopping it before it starts.
Okay. In global health, primary prevention is immunizations. It is sanitation. It is digging a well for clean water so cholera never happens.
Okay. In disaster.
It is building codes. It is making sure the hospital is earthquake-proof. It is the duck cover and hold drills in schools. It is making sure that Mountain Road is wide enough for evacuation.
And in violence.
It is parenting classes for new families. It is anti-bullying programs like Sources of Strength. It is changing the culture before the violence happens.
Okay, secondary prevention. This is immediate response and screening. The event is happening or has just happened, and we are trying to catch it early.
In global health, this is screening for TB. It is taking a temperature at the airport. It is treating pneumonia early before it becomes fatal.
In disaster.
It is the sirens going off. It is search and rescue. It is triage. It is setting up that field hospital.
And in violence.
Screening. That question during the prenatal visit. Do you feel safe? It is the crisis hotlines. It is identifying the red flags of trafficking in the ER.
And finally, tertiary prevention. The dust has settled. We are doing rehab and minimizing long-term damage.
In global health, it is physical therapy for stroke victims. It is managing the chronic condition.
In disaster.
It is the recovery phase,
Yeah.
rebuilding homes, but also, and crucially, PTSD counseling for survivors during that disillusionment phase we talked about.
Yeah, in violence.
It is support groups for survivors. It is safe houses. It is helping someone navigate the court system to get a restraining order. It is rebuilding a life.
See, it all fits into the same box.
It does. Whether you are dealing with malaria in Kenya, a gas leak in California, or domestic violence in a local clinic, the framework is the same. Assessment, intervention, prevention.
But doing this work, it takes a toll. We talked about the moral injury. The sources include a nurse's survival guide.
They do. And this is serious. They talk about compassion fatigue versus burnout.
What is the difference? I feel like we use them interchangeably.
We do, but they're different. Burnout is environmental. It is, I have too many patients, the computer system is broken, my manager is mean. You can fix burnout by changing jobs or fixing the system.
But compassion fatigue.
Compassion fatigue is internal. It is a cost of caring. It comes from absorbing the trauma of your patients day after day. It is when you start to feel numb. It is when you lose your ability to empathize because your tank is empty.
The sources say this is an occupational hazard, just like a needle stick.
Exactly. And the ANA, the American Nurses Association, declared a year of the healthy nurse to highlight this. Self-care isn't selfish. It is an ethical mandate. If you burn out, you cannot help anyone.
You cannot pour from an empty cup.
You can't. And part of that self-care is also self-reflection. We touched on this with implicit bias.
The Harvard implicit bias test.
Yes, we all have bias. We all have shortcuts our brains take based on stereotypes. It affects diagnosis. It affects pain management. Taking that test and acknowledging your biases isn't an admission of guilt. It is a professional responsibility to check your blind spots.
So we have laid it all out, from the daily to the red flags of trafficking. What is the final thought for our listeners?
I want to leave them with the concept of One Health.
What is that?
It is the recognition that the health of people is connected to the health of animals and the environment. We talked about wet markets and pandemics, animal to human. We talked about gas leaks, environment to human. We talked about violence spreading like a disease, human to human.
Everything is connected.
Exactly. In a world of increasing climate disasters, global pandemics, and systemic violence, the question for the nurse is, are you just treating a patient? Or are you treating the ecosystem they live in?
That is the question to mull over.
Don't just learn the definitions for the NCLEX. Look for the patterns. Whether it is a gas leak or a malaria outbreak, the skills remain the same. The world is your client.
And on that note, we will sign off. Thanks for diving deep with us.
Stay curious.